Welcome to the Call the Registrar session. We have two eminent speakers who will be discussing two emergency case scenarios that you will come across in your day-to-day practices. Our first speaker is Dr. Sunali Gunathilaka, Consultant Endocrinologist, District General Hospital, Nuwara. Dr. Gunathilaka completed her MD Medicine in 2015 from University of Colombo with gold medal for best performance. She did her overseas training at Oxford University NHS Trust and Cambridge University NHS Trust. Her special interest is in bone-related endocrine diseases and pituitary disorders. She contributed to several guideline development projects nationally and internationally. She is the author of several peer-reviewed articles published in international journals and book chapters in EndoTest. She will be discussing on patients with severe hyponatremia. Over to you, Sonali.
Thank you, Isha. So, very good morning. I think I might have to use the computer here and there, but I probably can come and discuss few things on the flow as well. So I can go there, right? Yeah. Because I would like this to be a little bit of interactive discussion. This is called the registrar theme, and then we are discussing about the acute management of different clinical scenarios. So I disclose there's no conflicts of interest. And this is my case. You have a very enthusiastic house officer who's myself, and you all are a bunch of very keen, very talented registrars. So I give you a call, and you are in the canteen having your lunch, and so I give a call and then tell about my case history. So 58-year-old male presented with generalized body weakness for 1 day and reduced level of consciousness for 4 hours. And 1 week back, he had taken treatment for cough and fever from a GP, and 1 day back had nausea and vomiting. So past medical history, he had dyslipidemia, hypertension and mild depression, and social history, he's a mechanic, ex-smoker, and occasional alcohol consumption. So examination-wise, temperature is 36.8 and BMI towards slightly overweight, and cardiovascular-wise normal, abdomen normal, respiratory rate is slightly increased, and there's mid-zone bronchial breathing, but the saturation is 95. GCSE is 12, but there's no focal neurology, no neck stiffness. And actually, patient has come with the basic investigations, which was done today morning, and full count was 12, HB was 12, platelets 450, I'm sorry about the printing mistakes, and CRP slightly elevated, sodium is 103, and potassium is 3.2. So my registrars and patient is basically stable. I'm managing the patient quite well, so you can come leisurely and have your lunch. And do you want anything else for me to do, or anything that you want me to run some tests or anything? I'm over the phone. Any thoughts? Well, I think there's no right or wrong answer, and you would benefit if you answer, and then let's make it a little bit of interaction. Right, okay. Serum osmolarity, urine osmolarity, okay, urine sodium. Sorry? Random blood sugar, okay. I'm writing it down. Yeah. Septic screening, okay. So I'm over the phone. Okay. You want me to start antibiotics? I would like if you can tell me a guidance. Okay. Right.
It's the confusion is that it's hyponatremic to start 3% sodium correction slowly.
Okay, right. 3%. How much? I have not used 3% before. Can you instruct me what to do, how to do?
We start 38 ml for 6 hours and then send a repeat sodium, send a repeat electrolytes and again reassess and decide on further correction.
Okay, right. Okay. Any other thoughts?
Slowly some IV potassium correction as well as potassium is also decreased low.
Okay, right. Fine. Okay, so I arranged all the blood investigations and I'm a little bit of kind of an enthusiastic house officer. I called the lab and asked how long will it take, and actually my lab, the MLT says it would take about minimum 4 hours, 5 hours to get serum osmolarities. Happy with that? And I'm going to start 3% sodium chloride as you suggested. Okay, all in agreement?
We can wait. Since the disease is still when patient is even if it's stable, I think we can wait for the osmolarity studies.
Okay, right, we can wait for 5 hours, 6 hours. Okay, and so without starting the 3% sodium chloride.
In case there is no deterioration, we can observe it.
Okay, I'll write, monitor for any deterioration, and once the osmolality start, we can consider 3%. Yeah, great, okay. Anyone who's not agreeing with that? It's okay, this is a learning experience and there's no basically right or wrong answer, but there's more preferable answer. Yeah? Okay. Glad to meet you, sir. Yeah, one of my mentors in medicine. Yeah, we can repeat sodium. Okay. So, mind you, you're still in the canteen having your lunch. A quick lunch, or you're going to have a nap after the lunch? Right. Okay. So you are having your lunch. I'm sorry, we can't see the. Okay. You're having your lunch, but things run in your mind. Okay, what are the problems? So, what are the problems? Acute ones, of course. Yeah. Okay. Exactly. Pneumonia. Right. Okay. Right. That's low GCS. Right. It's not 15. It's 12. Right. Why is the low GCS? Is it due to hyponatremia, or is it associated with some intracranial pathology? Because even intracranial pathologies can cause hyponatremia. Right, okay, you are still eating. Hyponatremia, you call it hyponatremia, yes, that is sodium less than 135. So you are correct there. Fine. Second problem is hyponatremia, and I got an answer saying severe hyponatremia. Why do you call it severe?
It's symptomatic as well as 103.
Right, symptomatic and 103. Okay, so severity of hyponatremia is classified in two different ways. One is biochemically, the other one is symptomatically. We usually, the European guidelines usually go with the symptomatic classification, and the management depends on the symptoms. Fine. So severity wise, number wise, severe hyponatremia is less than 100, sodium less than 125. Okay, you know that. It's in your mind. So severity of, depending on the severity of the symptoms, we call it moderate to severe and severe. right? If you have these symptoms. So if there is nausea without vomiting, confusion and headache, that is moderately severe. And then if there's vomiting, cardiorespiratory distress, abnormal or deep somnolence and seizures and GCS less than 8, it's severe. So where does my patient fall? Actually your patient, my patient, yeah. Severe? Yeah, why? Yeah. Yeah, but usually we go with symptoms as well, right? Patient had vomiting. We don't know whether the vomiting is causing hyponatremia or hyponatremia associated vomiting as a result of hyponatremia. But benefit of the doubt to the patient. Okay, and patient is drowsy, or the GCS is not less than 8, patient is drowsy. So you would put the patient into severe category. Okay, right. So all these things run in your mind and you decide this is severe hyponatremia. Well, as an inexperienced house officer, I would like my registrar to come running because I have no experience in managing a patient with sodium of 103. This is my first appointment, medicine. Haven't done anything, right? And I haven't seen even 3% sodium chloride. I don't know whether to reconstitute it or whether it comes in a bag. Okay. So that's severity. The other question is hyponatremia. Is it acute or chronic? It's acute. Okay. Why do you say it's acute? It's okay. Just open up your mouth, make a voice.
Patient is having symptoms as a respiratory tract infection symptoms, so most likely it will be associated with that as well.
Okay, yeah.
Even the vomiting sometimes can contribute to some sodium loss.
Right.
Usually, chronic patients would be able to, if the sodium is very low, he could be symptomatic either way, but ideally chronic patients will be the symptomatic and more than.
Right. Okay. Right. I'm kind of a very keen house officer. So if I ask, can it be acute or chronic? The patient had chronic hyponatremia and lower respiratory tract infection triggered this. And this is, mind you, 1 week duration of the lower respiratory tract infection. Can it be? Sorry?
Acute from chronic.
Is possible. Okay. Sorry. Okay, fine. So if you have a doubt of whether it's acute or chronic, what would you select? Yeah, if it is more than 48 hours, it is chronic. If it is less than 48 hours, it is acute. What would you select if you have a doubt? Exactly. So if you are not quite sure if it is acute or chronic, you go with chronic, right? Yeah, so acute less than 48 hours, chronic more than 48 hours or unknown duration of onset. Right? Okay, etiology. So you have this doubt, what is the etiology? Is it SIADH with pneumonia or is it solute loss with vomiting or combination, any other cause? It can be something else, right? Likely cause, yeah, I understand there's pneumonia, right? So these are my problems which are running in my head and you're having your lunch, but well, something triggers in your mind and okay, this is an inexperienced house officer and you should come to the ward and see the patients because I might miss a lot of things, right? Okay, so what's in your mind? It's severe symptomatic hyponatremia, right? That's all what you can gather from my history. So when you come, I ask, why are you here? I've been managing this patient well. Obviously, I'm not quite confident, but why are you here? Why, if you are to go to the ward, why do you go? Is it really important to go and see the patient? Because, so you tell me, I'm clueless, why are you here? So, high risk of cerebral edema and irreversible neurological damage and brainstem herniation and respiratory arrest leading to death in severe symptomatic hyponatremia. In addition, if it is acute hyponatremia, still all these are possible. And these are the causes of, just for your knowledge, causes of acute hyponatremia. If there is psychogenic polydipsia or someone using ecstasy or post-op hyponatremia, some hypotonic fluid consumption, especially in runners and malnourished patients and patients with burns. Or chronic hyponatremia with additional risk factors. So usually chronic hyponatremias, like you all said, it is asymptomatic, well tolerated, but if there's a second hit, they will deteriorate very drastically because to start with their sodium is low. And second hits, the risk categories are patients who are using alcohol, having seizure disorders, pre-existing intracranial pathologies, and sodium less than 110, they are at high risk of getting an additional second hit and going into severe symptomatic hyponatremia. Okay, so you told about the investigations. So someone wanted RBS and also very correctly repeat sodium, which would take about 3-4 hours. So the keen house officer did an ABG. And well, although it's not very reliable as serum, still it would go along with sodium of 103. This is 105, and potassium is also somewhat similar. Okay, you are with the patient. Somehow you came to the ward. What would you do in the ward? Anything else? This is quick things. You come running to the ward, and then next thing. So these are daily scenarios that you face. And we take it granted to manage the way we like, not following the guidelines, well, not all the time, but we think we can manage, but you have to go along the guidelines because guidelines and evidence is there with a reason, right? Okay, so so if there is a consultant would expect you to, I'm sorry, my hyperlinks are not working. So to go for a targeted history. So confusion. So what is in mind is low GCS with hyponatremia. Confusion could be due to any CNS pathology even. You can take a quick history whether there's trauma, focal neurology, fever, and then regarding hyponatremia. Severity of, I told you the symptoms of severity and the symptoms and clues for the etiology. So any fluid loss, yes, there was vomiting, any diarrhea, diuresis, pre-existing diseases, liver, renal, cardiac diseases, and any cancers that the HO couldn't find, any hormonal deficiencies like hypothyroidism, adrenal insufficiency, and any addictions. And clues for the chronicity. Have you ever done any investigations during the past? You had a GP visit last week. Did the GP run any test? So if you have a sodium of 140 a week ago, you know that it is, it was there, and this is not more than 7 days. This is within 7 days, still could be chronic, right? Okay, so I would actually expect to go for a detailed drug history because it is important. It is one of the keys, and this may be the only key sometimes. So the patient is on losartan, amlodipine, HCT, rosuvastatin, and vitamin D. And as an enthusiastic registrar, you go and ask for any antidepressants, any antipsychotic medications, or whether the patient is taking ecstasy or some recreational drugs. So these are important, right? This won't take much time. You know, if you are very organized, you know what to look for, right? So it's the quick history and the drug history is very important in hyponatremia. And I won't go into details, but there are lists of drugs which can cause hyponatremia. And in these patients, especially HCT and sometimes losartan also can cause, contribute to the hyponatremia. Okay, and then the registrar would do a quick examination to find out whether the HO has missed something. Fluid status is very important when you manage a patient with hyponatremia, not acutely, but in long run. But the initial examination is very important, not to miss things, because we are going to give fluids anyway, so you might miss the clinical signs. And then features of cerebral herniation, any papilledema, gaze palsies, anything, cerebral edema like. Okay. So other investigations I went through, and fine. Now next is other investigations are awaiting, still not 6 hours. So we are going for the treatment. Sorry. I'm sorry, my hyperlinks are not working, so I'll be using the normal way. This condition is a medical emergency. So we would expect the medical registrars, or if there's a SHO or house officer, to attend to this patient very rapidly. And yeah, you have to finish your lunch quickly and run, or not have the lunch and quickly run, right? Okay. The patient should be managed ideally in an HDU or ICU setting with support for airway breathing and circulation if needed. First hour of management is very important. And I'm just going through this because I got an answer for 3% sodium chloride. First hour, we use 3% sodium chloride because in acute severe hyponatremia, and this is the recommendation is 100 to 150. American and European guidelines slightly change, but boluses over 20 minutes. You give the first bolus, right? And then after 20 minutes, you take a blood sample for sodium. And then until you get the results, you continue another second bolus, right? And then repeat 3%, say, this is the second bolus, right? Then what are we going to do? Are we going to continue boluses all of a sudden? Oh, so you have to write, you have to instruct. What is the next step? Okay. What guides you for that? Yeah, correct. So you want to avoid rapid correction, which determines, are you going to see the patient and then, okay, now this is going to go for rapid and then I'm going to switch to maintenance, or what is your guidance? Okay, so this is in a chart or flow chart kind of a thing. So this I explained, and may repeat the 3% saline for 3 boluses until sodium rise is 5 millimole per liter. So your guidance is sodium rise, right? You don't just repeat whenever you think, or you don't just go along with somebody with information that you get from somebody. You go with evidence, right? Why 5 millimoles? Research has shown that a rise of 5 millimoles in sodium would prevent the consequences of acute severe hyponatremia, that is cerebral edema, herniation, respiratory arrest and death. So 4 to 6 millimoles rise would save the patient, right? That is within 1 hour you try to achieve. Okay, then when you have that increment of 5 millimoles, usually the patients improve symptomatically. Patients won't recover 100%, but there will be some improvement of the symptoms. So you are happy with that, and then what will you do? Then only you stop hypertonic saline, right? And then you can switch to normal saline. That is the minimum amount that you need to maintain the IV line, right? Because we have done some correction, and then you need to treat the specific, you have to find out what is the problem, and you need to treat the specific cause related to that patient. If it is pneumonia, you treat with pneumonia antibiotics, and like you all said. Okay, fine. If I can get the picture, the camera up, because it's disturbing. Yeah, so what are the targets? Now you stop saline, 3% saline, and you switch to the minimum amount of normal saline, and you treat the underlying cause. You can't just leave. There should be clear instructions in this patient for the HO or the SHOs to follow. So the target rise should be 10 millimoles in 24 hours and 8 millimoles per 24 hours thereafter. Right? That is the target that you told. Right? Good. Okay, so we have clear instructions now, and then HO asks, when do I have to repeat the sodium? Again, you have to clearly tell, okay, at least 6 hours, at 6 hours, 12 hours, and every day, every 24 hours, once the patient is stabilized. If the patient is not stabilized, even 4 hourly would be fine. Okay, so your patient is improving. What if the patient's symptoms are not improving? What will you do? Any guesses? Because these are common things. I, of course, get hyponatremic patients. Some are severe, once in 2 months at least. Okay. Without taking much time, I'll rush through. If the symptoms are not improving after 5 millimoles per liter rise of sodium and 3 boluses of 3% sodium chloride, which we have given already, then you can switch to 3% sodium chloride infusion to achieve 1 millimole per liter per hour rise. Right? This infusion can be based on a formula. We have formulas to calculate the sodium chloride rate, or it can be weight based, 0.5 to 2 milliliters per kg per hour. It depends. You have to weigh the pros and cons, and also the body weight and patient's condition. So there, sodium should be checked every 4 hourly while the patient is on infusion. And then obviously need to treat the specific cause, and you stop 3% sodium chloride once symptoms improve, or sodium rise is 10 millimoles per liter in total, or when the sodium reaches 130. So that's when you stop the 3% sodium chloride infusion. Whichever occurs first. You don't wait for all three, which occurs first, then you stop. Then the problem comes if there's no symptom improvement after 10 millimole per liter rise, what we will do? What are we going to do? Then you have to look for some other cause for these symptoms, right? There can be so many other causes for these symptoms. Okay. Then this is slightly deviating because I want to cover the other aspects also. Imagine this patient is moderately severe symptomatic hyponatremia, either acute or chronic. Like this patient is not having seizures or anything, just having nausea without vomiting and some headache with low sodium. Or acute asymptomatic hyponatremia with a 10 millimole per liter drop. So acute, but sodium drops from 135 to 120 acutely without any symptoms. Usually they get symptoms. In that case, you try to diagnose, find the cause, and stop medications and treat the underlying cause. But you may use 1 bolus of 3% sodium chloride, 150 ml IV over 20 minutes and repeat sodium levels, because this can lead to severe symptomatic hyponatremia. To prevent that, you use 1 bolus and then treat the underlying cause. Okay. What is our aim? Sodium rise of 5 millimole per liter for 24 hours. That is our aim, because this is mild, had not gone into severe symptomatic level, and not to rise more than 10 millimole per liter for 24 hours. little bit of numbers, but when you practice this, actually you will understand this is all the same, right? Or until the sodium is 130. Okay, and then monitor sodium frequently, and then thereafter one stable every day. Okay. Another important thing when we do this and when we give this 3% sodium chloride is sodium overcorrection. Are we giving too much? Because I have told the cutoffs, and then according to the cutoffs, are we going beyond the cutoffs? Sodium overcorrection leads to osmotic demyelination syndrome. What is that? You may, sorry. Yeah.
Actually, we're running out of
Yeah, I'm in the last bits. So if you do acute correction, there's a risk of overshooting the sodium. And then there are a lot of neurological symptoms. And then how can we prevent? You monitor sodium and then not go beyond the limits. Or there is a place for desmopressin used with 3% sodium chloride. And then I will skip this and just show this slide only. You can use proactive strategy with 3% sodium chloride. You can use DDAVP, or you may use, when the sodium rises, you may use intermittently like in the second one, and also just one when the sodium tries to shoot. Or else, if it shoots, then we have to revert it. Then if it goes beyond like 20 millimoles, you use desmopressin to revert it, and we call it rescue strategy. Most of the time we are called for this. Okay, these are the investigations that you all wanted. Osmolalities, serum sodium, urine sodium, and thyroid cortisol are normal, liver renal normal, CT normal. Triglycerides and serum proteins should be done to exclude pseudo hyponatremia. And yeah, the rest is normal protocol of evaluation of hyponatremia. So learning points: severe symptomatic hyponatremia is a medical emergency. You need to rush and treat, otherwise patient will end up in neurological sequelae, and severe symptomatic hyponatremia may lead to cerebral edema, brainstem herniation. You need to use 3% sodium chloride within 1 hour with targets, and then overcorrection would lead to osmotic demyelination syndrome, and early detection, anticipation, and correct how do you call it? It's rapid recorrection of overshooted sodium would benefit the patient and will prevent a catastrophe. Okay, thank you. And this has nothing to do with my presentation. This is where I work. Thank you very much.
Thank you very much, Dr. Gunathilaka, for your very comprehensive and thorough lecture on managing patients with severe hyponatremia. And thank you very much for you all for the very interactive session. May I now invite our second speaker, Dr. Bhatia R.D. Ranasinghe, consultant cardiologist, Base Hospital Kalutara, to start his the case discussion on patient with unstable supraventricular tachycardia.
Good morning. Thank you very much, Varsha, inviting to deliver this important topic. Sorry for being late. I supposed to be the first presenter, right? So anyway, it's about unstable SVT, right? SVT is a common emergency that you see in day-to-day practice in the ETU. At least you will get a 1 SVT per day in the emergency. So it's very common. Not only in the ward emergency, but also it can happen in the ward as well as in the outpatient. So before going to SVT, it's very important that you have to have understanding about the conduction system of the heart, where it starts in the SA node and goes to the AV node, and through the his Purkinje system, the bundle branches. So anything above here, you can get SVT. It can be at the atrial level, it can be in the AV node, right? It can be the bundle here, and also it can be the atria or the pulmonary veins. So SVTs are anything that happens above the atrioventricular groove. So let's start with the patient. Actually, this patient presented when I worked at Karapitiya. 60-year-old patient presented 4 times to different hospital with chest pain and managed as non-STEMI. And second time, when every time he presented with a troponin rise. And second time, he was undergone angiogram. And angiogram showed just 90% coincidental diagnosis of diagonal 90% stenosis, diagonal artery. And he again presented for the 5th time to base hospital Balapitiya and with same symptoms. And this ECG was taken. Sorry for the clarity of the picture, but that means patient has present with recurrent, according to diagnosis, recurrent non-STEMI. But in fact, it is not non-STEMI, because if you have a rapid heart rates, even if you have a background coronary occlusion, then you can get a troponin rise, right? So manage not detected. But fortunately, this ECG was recorded when he presented to Balapitiya hospital. And in fact, this of course, is it narrow complex or broad complex? If you present with SVT, if you are called to the emergency, you have to first see whether it's a narrow or broad. Is it narrow or broad? It's broad, right? So it's a broad complex. And then what is the problem? Now, if it is a broad complex, what is the pattern you can see here? Is it like a right bundle or a left bundle? It's a right bundle. Is it a typical right bundle or is it an atypical right bundle? It's a typical right bundle, right? So you can see RSR pattern in V1 and S wave in here, right? Okay. So if you have a typical right bundle branch block pattern, it's not a VT. It's not a VT. So if you have an atypical bundle branch block pattern, then it's likely to be a ventricular tachycardia. That is the golden rule. So it's a typical bundle branch block with the right bundle. Now if you clearly look, there's a hidden P wave underneath, right? Just after the QRS complex. Sorry for the clarity. And then what is the diagnosis? So and the other important thing is, what is the rate? Right? See, so it's around 180, right? 180, somewhere around 170, 180, right? Now you are called to the emergency, right? And they say, okay, this patient present with palpitation, this is the ECG. What is your first question? You are allowed to run. You are running to the emergency to see it. So what is your first question? Number 1, blood pressure, right? While you are running and you ask, what is the blood pressure? Right? If the blood pressure is normal, you can dress up nicely and you can go. If the blood pressure is unstable, like 80, then you are worried, right? If it is blood pressure is unstable, what is the management? Then cardioversion. How much? Synchronize. How much? No, that is not necessary for SVTs. You give 50 joules synchronized cardioversion. 50 joules of synchronized cardioversion, right? But only problem is if you give cardioversion, there's a theory that how you give it, you have to have the good contact, keep the pedals pressed first, and then deliver the shock, synchronized. Most of the time people are, just don't keep it pressed. Therefore, you don't get the direct current to the heart, because sometimes you can get burns, right? So you push it and then give the 50 joules of synchronized cardioversion. Now, this same scenario happens sometimes. You can have irregular rhythm, right? Patient have, now this is a regular broad complex tachycardia, but it's finally proven to be SVT, right? But you can have irregular rhythms. What? Atrial fibrillation. So if it is a patient which comes with atrial fibrillation, so what do you do? Blood pressure is still 80, they call, and those things happen especially in elderly groups. The like AVRTs, the AVNRTs, most of them happens in the young group, but patients with old age group or sometimes associated valvular heart disease like mitral stenosis, they can present with AF, right? In that scenario, blood pressure is 80. What is your next question? What is your next question? Patient is symptomatic, patient is unstable. Atrial fibrillation, fast, 180 or 190. What is your next therapy or what is your next question? again shock. How much? How much? 150 or even 100. 100. You can start with 100, even 150. If you tend to give little higher energy than the other regular SVTs, right? Okay. So are you clear? Right. So diagnosis is, in fact, it can be sinus tachycardia. Have a clear look, right? And it can be VT because it's broad complex. It's AVNRT, AVRT. So it's a AVNRT. Fact that there's a small P wave after the QRS complexes. And the SVT is due to AVNRT, that is atrioventricular nodal reentrant tachycardia. The heart rate sits around 150 range, 150, 170. But AVRTs tend to be more rapid, right? AVRTs, the heart rate tend to be more rapid. So the RR interval is shorter in AVRTs, right? Okay. So how do you approach? I have already told. First question to ask, blood pressure. So what are the symptoms of cerebral hypoperfusion? So that means that you are dealing with an unstable SVT. What are the symptoms of cerebral hypoperfusion? Confusion, right? Actually, most of the people are confused, right, with cerebral hypoperfusion, right? So if you ask few questions, right, and if the blood pressure is low, of course, you didn't know to ask questions, right? You can straight away go with the therapy. Now even if it is AF, if the blood pressure is low, do you ask the duration of AF? No, you don't ask the duration of AF, right? Now, whether is a clot or whatever inside, what matters is first, right? If the blood pressure is low, patient is unstable, so stabilize, right? Otherwise, otherwise the patient's blood pressure is normal, then you ask whether it's acute or chronic, whatever, right? More than 48 hours or less than 48 hours, like that, right? So, what are your treatment strategies? Right? Now, you dealt with a patient. Sorry, I'm not only talking, right? Just few slides, right? So you are dealt with the patient who have unstable blood pressure with the SVT. And you have a patient now, blood pressure is normal. They say blood pressure is normal. Are you want to hurry? No, you don't want to hurry. Even in fact, the blood pressure is unstable, SVT, you can give over the phone advice or give you a synchronized cardioversion. But just before that, try to get the ECG. Sometimes it can be sinus tachycardia. You understand what I am saying? So you can have sinus tachycardia due to hyponatremia, hemorrhage, right? Maybe some other reason, fever or whatever. Sometimes patients can have sinus tachycardia with heart failure due to low ejection fraction, right? Just to get the ECG on WhatsApp. You don't want to go to emergency, right? Just have a ECG, have a look, and then you can give advice. Okay, give a shock. Because you can be 15 minutes away, right? You can be 30 minutes away. So you can say, okay, this is the ECG, looks like SVT, right? Give a shock. Otherwise, only thing that you need to exclude is sinus tachycardia, right? So if it is, blood pressure is stable. So what are the things you can do? Now you can slowly dress up and go to the emergency and you see the ECG. You attach to the monitor, you expect a 12 lead ECG. You can have enough time now. You have enough time now, right, to play. You get a nice L2 rhythm strip. Over the phone, you say, okay, get a good ECG. Attach to the monitor, right, and monitor the saturation, right, and look for blood pressure. The blood pressure is stable. Now you are slowly going, and you have a rhythm strip, right, and it's stable, SVT. Say it's AVNRT or AVRT. So what are things you can do? You can do physical maneuvers. So what physical maneuvers? One thing is you can try carotid sinus massage. I'm sure everybody knows how to do the carotid sinus massage, right? You auscultate, it's not necessarily so, and you press over the, right, cricoid, right, here, right? And then Valsalva. How do you do Valsalva? Now you are called and you are advised and your house officer is waiting, house officer is asking how are you going to do Valsalva? Patient doesn't know what is glottis, what is thing. So what is the simple thing you do? How do you perform Valsalva at the ETU? Now, blow into a syringe. What is the syringe? 20, right? 20 ml syringe. You can take it and then it's closed and blow it. The other side. Then this has to move, right? So if you do it, that maneuver, then you activate in the Valsalva, right? So you must know. Don't tell in the exam, so I'm allowing the patient to blow against the closed glottis. I mean, Siripal, whoever doesn't know what the glottis is, right? Okay, so you correctly say, take a syringe, 20 cc, right, and blow it, get a deep breath inside and blow it, right, and then that is Valsalva, right? You have to know these maneuvers to do it, right? So, and then you done it and it's failed. What is the next? What is the next? So, you can try the medications. So, what medications? IV adenosine. But before giving medications, or before even trying the physical maneuvers, patient has to be in a monitor where you monitor the ECG, because sometimes patient can go into asystole, sometimes patient can go into long pause. Even with the slowdown of the heart rate, you can even see the background rhythm. It can be atrial flutter with 2:1 block, because sometimes it's difficult to see. 150 beats per minute, you can get atrial flutter with 2:1. When you slow down the monitor, you can see the flutter waves in between. Then you know it's atrial flutter and get a rhythm strip there. Then you made the diagnosis, right? Okay, so IV adenosine, 6 milligrams, right, you give as a bolus, because it has to be fast and have a flush syringe, because why? It's a short acting, right, and make sure you exclude asthma, right, and then of course if not, you can try IV verapamil and sometimes beta blockers. So beta blockers generally you try to avoid in AVNRT, atrioventricular nodal reentry tachycardia. You basically give IV adenosine and verapamil, right, and verapamil they say and digoxin you try to avoid in AVRT, atrioventricular reentry tachycardia. Why is that? It's not contraindicated. It's not contraindicated. You can give it if you are not sure about the arrhythmia, but what can happen in AVRT? Atrioventricular reentry tachycardia is where the pathway is associated. So if you give blockers, what will happen? You are blocking the normal AV node with calcium channel blockers and also digoxin. So if you block the normal pathway, what can happen? It can conduct through the accessory pathway, and then you can get a rapid ventricular response. Even suppose if you have AF with AVRT, you can get it. AF with ART, then what will happen? What you have in the AF in the atria can conduct through the accessory pathway to the ventricles, and you can regenerate into VF, right? These are theoretical but not contraindicated. As long as you are in the ET, you can manage even VF, right? It doesn't matter, right? So but you try to avoid in AVRTs. So DC cardioversion, general to SVT is 50 joules synchronized. Even they say 10 to 50. You don't want to take a chance. You say 50 joules. Right? If it is not reverted, because otherwise you have to give it again, right? Give 50 joules, right? If it is AF, how much? 100 joules, right? So he became unwell, as I mentioned, blood pressure dropped, and of course cardioversion. Now case number 2, this young child came to emergency department with fever. Blood pressure is, low, towards lowerish side, right? 80. So what is this? Sorry about it, but it's a sinus tachycardia. You can see the P wave. Can you see the P wave here? That's the P wave, right? So P wave before the QRS complex. So it's a sinus tachycardia due to fever. If it is even blood pressure is normal, are you going to give medications here? No. You try to see why patient is tachycardic. Correct the cause. If it is hypovolemia, you correct it. It can be myocardial ischemia with pump failure, right? Try to do revascularization or whatever, right? So it depends on what the etiology. So you correct the leading cause for the sinus tachycardia. And then 25-year-old female patient present with palpitation. The following ECG is recorded. So what is the difference here the ECG than compared to what I presented first? Is it narrow or broad? Is a narrow complex tachycardia. If it is narrow complex tachycardia, it is more faster, or is it more towards moderately faster? Is it faster? It's very fast, right? It's relatively very fast, right? Almost like 300, almost like 220 or something, right? Okay, right? And then this is a narrow complex tachycardia and relatively fast tachycardia. What is the likely possibilities? Is it regular or irregular? is regular. So regular, narrow complex, tachycardia, relatively faster. What is the most likely diagnosis? SVT. SVT due to AVRT. Now you are getting there, right? So AVRT. SVT due to AVRT, atrioventricular re-entry tachycardia. Is it using which pathway? Normal conduction or the other way? Because you can have orthodromic or antidromic. Right? This is narrow complex. Then one of the differential diagnoses with SVT with, you can have SVTs with broad complex. Right? So what are the causes? Like SVT with bundle branch block, SVT with aberrant conduction. Right? Here accessory pathway. Right? So AVRT with narrow complex tachycardia. Are you clear so far? Are you clear so far? Right? Now in these patients, if you take a ECG after settling, you give physical maneuvers, you give the drugs or whatever, and done everything, and after settling, if you take a ECG, what will be the ECG? Normal sinus rhythm. Very important to see the normal sinus rhythm, ECG, after correcting the arrhythmia. So what will be the ECG? No, you don't get delta wave here. That's the very important thing. Most of the accessory pathway tachycardias are, the pathway is hidden. Right? Okay. The other way around, if you have a broad complex tachycardia, sometimes you can get, but mostly you won't see it sometimes. You understand? Sometimes there can be, right? There can be, you might see a delta wave, right? Most of the time it can be hidden, right? So absent of a delta wave does not exclude a WPW or accessory pathway mediated tachycardia. Understood? That's the other method that other message that I want to put you. Right? Why is that? Now you do it, now SVT you treated, this is a AVRT, and you take the rhythm strip or whatever after settling the tachycardia, it doesn't show a delta wave. Your diagnosis is accessory pathway tachycardia. What is the reason? Because a sinus rhythm, the accessory pathway is not conducting through the accessory pathway. It goes only through the normal conduction system. So therefore, you don't get a pre-excitation. Clear? Right? Okay. So absence of a delta wave, even though you make a diagnosis of AVRT, right? Right? So it doesn't exclude pathways. Understood? Right. This 25-year-old male patient present with palpitation and his blood pressure is normal. Again, it's a AVRT, so it's a narrow complex tachycardia, right? Okay. So I told you what medications, what physical maneuvers, what is the role of cardioversion, what is the definitive treatment. Now, these are the initial measures you take. If the blood pressure is unstable, you give a cardioversion. If the blood pressure is normal, you try all these physical maneuvers, the drugs and all that. Now, what is the prevention? How do you prevent? That is the other thing. Now, patients can present with sometimes once in 3 months, once a month, once a year, sometimes once for 5 years. Right? So how do you prevent? What is your next strategy? Then you ask the history. Right? How frequent you get these episodes of palpitation? Then they say, okay, I get once a month. Right? And then when the patient come to you, sometimes tachycardia is not seen. And then you say echo done, Holt done, normal, you can go home. Is it true? No. Why? Holt is only 24-hour monitoring. Now sometimes patients can come with episodic palpitations. If you do a Holt, a normal Holt does not mean that patient has a normal. Understood? Clear? Why is that? Because palpitation, if you ask this, he says only once a month. While doing the Holt monitoring, it can be normal. Right? Okay, that doesn't exclude normal, the patient's symptoms are wrong. Don't say patient symptoms are wrong. He may be getting a nasty arrhythmia once a month. Can be once in 6 months. Clear? Right? Okay. Then in that case, if you monitor really, what do you want to do? Either you can do extended Holter like 48 hours, but still may not detect because once a month tachycardia. If you get a daily tachycardia symptoms, then you can detect in the Holter. Right? So what do you do? You can do a loop recorder. What is a loop recorder? Loop recorder. We are like a pen drive like thing. We can implant inside and you can kept it for 2 to 3 years. And then you ask the patient, okay, moment you get a tachycardia, come to hospital, and then we can analyze the rhythm inside. We can retrospectively go back and see what are the episodes. He will say, okay, this date at 9 o'clock I got the symptoms. You go back, exactly you can figure out what the arrhythmia then, and you can make a diagnosis. Clear? Right? Okay. So I think last 2 or 3 slides, right? So 75 patients present with confusion and hypotension. What is this? What is the ECG? Is it narrow complex or broad complex? Narrow complex. Is it regular or irregular? Irregular. Are there P waves? Are there, look at the rhythm strip down. Are there P waves? There are P waves. See that? Here. But is the P waves different in morphology? If you look, each P wave is different. More than 3 configurations. You can see. Right? So what is this? Multifocal atrial tachycardia. So you can have SVTs with irregular rhythm. That is 2. Actually, one is atrial fibrillation, other one is multifocal atrial tachycardia. Are you clear? Right? Generally, the atrial tachycardias and multifocal atrial tachycardias happens in elderly group. Right? Generally. Right? So AVRTs and AVNRTs mostly happens in middle group or younger group. But elderly also can get both AVRTs and AVNRTs. Right? So this is the pathway that I have mentioned about AVRT. You can have normal conduction, which is called the orthodromic conduction. Antidromic, where through the pathway it happens, right? Okay, that's where the pre-excitation. So it happens first. Why you get a wider complex when the tachycardia happen antidromic? What's the reason? Why? Why you get a broad complex if the tachycardia happens through the accessory pathway and goes up? What's the reason? Because it first depolarizes the ventricle. Remember about a bundle branch block pattern. If you have a bundle branch like a left bundle, so where's the first depolarization happen? Right ventricle. Why left bundle is blocked? That's why you get a wide complex. So same way is antidromic tachycardia. Either pathway can be right-sided or the left-sided. Right? Okay. So here it appears like a left bundle. Why? It first depolarizes the right ventricle. So if the pathway is on the left side, it appears like a right. Clear? Right. Right. So you get my point, right? So those are important facts. So this patient actually presented again with tachycardia, palpitation. Actually, patient did not have symptoms, no palpitation, but the ECG detected atrial flutter, right? And 2:1. And if you look, there's a P wave, there's a P wave. Can you see 2 P waves there? Right? See, one here, notch. Here, one there. 2 notch, right? Atrial flutter. When you give the medication, you can nicely see the flutter rate. So atrial flutter and atrial fibrillation manage same way. Look whether a patient is hemodynamically stable or unstable. If it's unstable, you give cardioversion. Stable, then you look for duration of wave, whether it's 48 hours or more than 48 hours. How do you know that it's 48 hours or not 48 hours? How do you know? Symptoms, right? You ask for the symptoms. Then patient will say, right? And it is less than 48 hours, you do the. Now cardioversion in AF, both chemical cardioversion and electrical cardioversion for chronic AF is equally bad. I know most of the people start amiodarone infusion. AF, okay, start amiodarone infusion. Is it bad? Yes, it's bad. The blood pressure is stable. Chronic AF, don't start amiodarone infusion, please. Why? There's a risk of clot and come into sinus rhythm and embolize. I know most of the thing, amiodarone is you give advice. Am I clear? Right? Most of it is wrong. But either a chemical cardioversion or the electrical cardioversion, both have the same effects. Right? Don't do it. Then you give rate control. Right? If it's a chronic case, rate control and what? Assess for need for anticoagulation, stroke risk, either CHATS-SCO, CHATS-VASCO, and then you assess for the stroke risk. If its risk is high, you start anticoagulation. If it is, then the choice of which anticoagulation. If it is a structurally a normal heart, no mitral stenosis, what is the anticoagulation of choice if you have it? NOACs is better. Novel anticoagulation like rivaroxaban or apixaban, right? That's better. Or dabigatran. Is it available in Sri Lanka? Now rivaroxaban is widely available. Widely available. Any pharmacy you have rivaroxaban now. Is much better. You need not to monitor, right? Okay. If it is valvular AF, like mitral stenosis, you tend to give warfarin. Clear? But warfarin can be given in both the groups. But the problem is warfarin always, you know, the side effects, the monitoring, the INR, the all sort of issues, right? So atrial tachycardia. This is again you can see the P waves. Why this I call atrial tachycardia? Why? Because if you do the L2 rhythm strip, the P wave is negative. Can you see that? Generally, L2, the P wave is positive. That means it's arising either left atrium or somewhere, right? So atrial tachycardia, right? And multifocal atrial tachycardia I already discussed, right? Different P wave configurations, right? So next, before concluding, SVT with wider QRS complexes. So two things, SVT with bundle branch block, SVT with aberrancy, but I already explained that, right? However, now even if you get a SVT, even broad complex tachycardia, the patient is unstable, are you going to work out and say it's a SVT? No, you always think it's a VT. If you are not sure, broad complex tachycardia, patient is unstable, until proven otherwise, it's always a ventricular tachycardia. Always a ventricular tachycardia. Don't try to figure out and say this is a SVT. Don't try to argue and try to find out this is what, right? No, it's a VT until proven otherwise. Clear? Right? Right. So management of tachycardia, any tachycardia, mind you, the SVT or a VT, what is the first question to ask? Blood pressure. If the blood pressure is low, that means hemodynamically unstable. And then patients will have symptoms. Then you give cardioversion. How much? 50 joule for normal SVTs and atrial fibrillation 100 or 100 to 150. Now the blood pressure is stable. Then what is the ECG? You have time now, L2 rhythm strip. You look whether it's a regular or irregular. If it is regular, what are the possibilities? AV-NRT, AV-RT or atrial tachycardia, right? If it is irregular, oh, and the other thing is sinus tachycardia, right? Okay, if it is irregular, AF or multifocal atrial tachycardia and sometimes atrial flutter with variable block, right? And the management is physical maneuvers you can try. I mentioned you how to do it. And then the medications and, right? And those things can be done. And now I have covered it. Now when it comes to prevention, now patient getting recurrent symptoms. So what medication you start long term? You can try calcium channel blockers. You can try beta blockers. If patient is still symptomatic, suppose if you start and patient has recurrent symptoms coming, right? What is the next therapy? Most of the SVTs are curable. Most of the SVTs are curable. So you don't want to add patients like 20-year-old females or males or long-term lifelong medications. Please don't do it. If the patients are symptomatic, you refer them for electrocardiophysiologists and they can ablate. Either AVNRT or AVRTs can be successfully ablated and the lifelong cure. Right? So that is your long-term goal. Right? Thank you very much. And any questions, or do I need to wait, or I'm done?
We can we can accompany few questions if you have.
So any questions?
Like when we are using anticoagulation,
Yeah.
apixaban and all that is superior, sir. But in case if a patient gets a hemorrhage and all that, the reversal will be issues.
Yeah.
In that case, do we still proceed with rivaroxaban or we consider warfarin since we were doing?
Still, I will go for the NOACs because in our setup, it's very difficult to manage the INR level. I know I have 1,000 problems. In fact, I have started now referring my patients for the warfarin clinic, anticoagulation clinic, because it's a real problem. Because how much now do you get your target INRs correct? Most of the time, not. Most of the time, not. Right? It is not achieved. Right? Either next when you increase to 10 and the patient will come with ICH, right? You increase only 1 milligram, and the INR reports are also in this country is a lot of unreliability, right? And then patients come with 10 and ICH, and sometimes you don't see the tip of you only see the tip of the iceberg. They present with neurosurgical units and other units. Then I think for Sri Lankan people, I think it's better to have anticoagulant which you don't want to monitor, right? I agree with your question because of the reversal problems, but still I think it's a minor issue in consideration of the major impact you get from warfarin. Right? One thing is you don't get therapeutic. Other thing is sometimes you get over, and patients are very unreliable. They don't come. They continue to swallow warfarin. There are patients whom I'm sure every physician, everybody knows that they have not done INR for last 4-6 months. Haven't you seen? Patients, they come, the first presentation can be a massive ICH or stroke, right? Unanticoagulated, right? So I prefer better to be, but problem is the cost. Problem is the cost, right? In anybody, if you ask a bit of social history, if you can afford, and you can give some statistics, how much INR blood test will cost? How much? Now, 1,000 already then 1,500. I don't know how much. Varsha?
It's around 1,500.
1,500. No, somewhere around 1,500. Okay, you 1,500. Now, rivaroxaban. Suppose if you elderly people, you need to give 15 milligrams per day. How much a tablet? Like 110 or 150, we'll say. So INR test at least 10 days you are covered. No, now for the blood test. You understand? Further, you need this much to take. You talk to the patient. Immediately, buying power is less. Why? Because immediately you see, my goodness, it's 150 tablets a day. But if you cost her like, you have to do monthly INR. And you don't want to, you can eat anything. Right? Okay, you asked not to eat green leaves and blah blah, not to take vitamin and vitamins then not there, it's a lot of problems. What do you want? Then they say, immediately they say, I'm happy with rivaroxaban. So whoever patients I have put on rivaroxaban or whatever, apixaban, they are very happy with me. That's one of the ways that you can retain your patient. Bharatiya Ranasinghe, right? That's one of the ways that you retain your patient, right? Okay, any questions?
I think.
Okay, done, no?
Okay, thank you. Thank you, Dr. Bharatiya Ranasinghe, for the excellent and very practical talk on managing SVT. Thank you very much for both of our speakers. On behalf of the Ceylon College of Physicians, I express my gratitude for both the speakers for the excellent presentation, and for the audience. Thank you very much for your the participation, active participation, and I want you all to come for the tomorrow's session as well. So we will be having the similar sessions for you all tomorrow from 8 a.m. to 9 a.m. Please be there tomorrow as well. So we will wind up today's session. Thank you very much and have a good day.